For a patient, the transition from the hospital bed to the front door is the moment of maximum vulnerability. They walk out holding a stack of complex discharge papers, stepping into a gap where medical treatment ends and the confusing reality of managing a chronic recovery begins. Inside the home, that confusion is completely silent. But on the smartphone in their pocket, the healthcare industry is incredibly loud. It's a constant stream of highly targeted digital advertisements for MRI machines and specialist consultations, even as the patient struggles to understand their basic daily medication. This disconnect exists because the healthcare ecosystem in Bangladesh is optimized for treating patients, but it structurally ignores teaching them. Hospital wards are packed to the brim, staffs are stretched thin, and every ounce of energy goes into acute medical intervention. There is simply no room left for structured education. Surviving a hospital visit loses its medical and economic value if a patient lacks the practical knowledge to survive at home between visits. Look at the data. Chronic non-communicable diseases now account for 67% of all deaths in Bangladesh. The financial reality is equally staggering. With public health spending below 1% of GDP, 69% of health expenditure comes directly from patients' pockets. Without structured health literacy, a predictable cascade begins. Patients mismanage chronic conditions at home, return to the hospital sicker, requiring far more expensive medical interventions. These bills eventually push their entire family into systemic debt. This cycle of chronic medical debt stems directly from the system's design, far outweighing any individual effort a patient can make. The public sector alone cannot fix this. The private healthcare sector now handles over half of the total healthcare demand in the country. To capture that market share, the private sector has built an immense communication infrastructure. They command thousands of digital platforms, run dedicated call centers, and employ marketing teams that reach millions of citizens every single day. But there is a flaw in how this network operates. Without a policy mandate, it remains commercially irrational for private hospitals to invest in health education. Consequently, this massive network is strictly limited to pumping out promotional content and service advertisements. Contrast that omnipresence with the public sector's efforts. The government relies heavily on seasonal, episodic pushes, like youth rallies holding signs to prevent dengue. It is well-meaning, but constrained by limited budgets and brief campaign windows. Bangladesh has built a massive, functioning health communication network that currently operates without a strategic public health objective. Transforming everyday promotional marketing into behavioral public education would change the entire trajectory of the system. Consider a standard promotional profile for a cardiologist on social media. With a minor content tweak, that same digital real estate could include clear guidance on the warning signs of uncontrolled diabetes, teaching patients exactly when a symptom requires urgent evaluation. The same logic applies inside the hospital. Standard discharge instructions and brief check-ins with nurses can be reimagined as structured behavioral training sessions, equipping the patient for the weeks ahead. Individually, these changes cost almost nothing to implement, but when multiplied across millions of private patient interactions every year, they reshape how an entire population relates to its own health. Solving the health literacy crisis relies on rewriting the existing private machinery, rather than building a new, expensive government bureaucracy. To make that realignment happen, we need specific policy valves. The foundational step is granting the Directorate General of Health Services the clear mandate to set and enforce national health education standards for the private sector. Looking at this flowchart, we can see the primary economic lever. By tying hospital accreditation weighting or targeted tax benefits directly to a private provider's health literacy output, the policy creates a loop of institutional self-interest. The secondary lever is a public-private compact. During outbreaks or emergencies, critical government health messaging taps into this new pipeline and flows automatically through private networks, multiplying the state's reach instantly. This shift creates immediate demand for a new professional workforce, public health education and promotion specialists, trained in behavioral science, embedded directly inside private hospital communication teams. By aligning national public health objectives with institutional self-interest, educating the public shifts from an act of charity into a commercially rational business strategy. Returning to the diabetic patient from our opening, We now see them leave the clinic referencing structured digital follow-up guidance on their phone, completely aware of how to manage their care. That level of informed patient behavior is the only sustainable way to prevent severe medical complications and halt the cycle of avoidable, crushing debt. When you zoom out from that single patient, you see the true scale of the opportunity. There are millions of these interactions occurring across the country right now, every single day. The infrastructure required to educate the nation is already built. It is fully active, operating in our pockets, and visible on our streets. The final question is whether Bangladesh will allow its most powerful communication network to remain strategically wasted, or finally harness it to empower its people.